75% of heart attack patients had normal cholesterol. The science your doctor missed. Here is a number that should stop you cold. Cardiovascular disease kills more Americans every year than all cancers combined. It accounts for 1 in every 3 deaths in this country. And despite decades of public health campaigns, despite statins being among the most prescribed medications in American history, despite an entire culture of low-fat dieting that dominated medical advice for 30 years, the rates of heart disease in adults over 50 have not fallen the way anyone predicted they would. That gap between the intervention and the outcome tells you something important. It tells you that the model we have been working from is incomplete. Here's what I mean. The conventional framework goes like this. High LDL cholesterol causes plaque in your arteries. Plaque causes heart attacks. Therefore, lower LDL prevent heart attacks. That framework is not wrong, but it is dramatically oversimplified in ways that leave the majority of cardiovascular risk completely unaddressed. Consider this. A study published in the Journal of the American Medical Association found that nearly 75% of patients hospitalized for acute heart attacks had LDL cholesterol levels that were considered normal or even optimal by standard guidelines. Normal cholesterol. Heart attack anyway. Because cardiovascular disease is not primarily a cholesterol storage problem. It is an inflammatory disease. It is a vascular aging disease. It is driven by insulin resistance, oxidative stress, endothelial dysfunction, and the accumulation of specific lipoprotein particles that standard cholesterol panels do not even measure. Today I'm going to give you the complete science of cardiovascular health after 50. The biomarkers that actually predict risk, the dietary and lifestyle interventions with the strongest evidence, and the conversation you need to have with your doctor that goes well beyond your total cholesterol number. We will dive into all of that in today's episode. I am Dr. Alexander Wellrich. Cardiovascular health is the topic that connects every other episode in this series, because the heart and vascular system are affected by mitochondrial function, gut microbiome composition, chronic inflammation, hormone levels, sleep quality, muscle mass, and biological aging simultaneously. Everything we have discussed comes to bear on the health of your arteries and your heart. And yet the conversation most people have with their doctor about cardiovascular risk is reduced to 3 numbers: total cholesterol, LDL, and HDL, and a decision about whether to prescribe a statin. That conversation, while not useless, misses the majority of what the current science tells us actually determines your cardiovascular future. In 30 years of clinical practice, I have watched patients with excellent cholesterol numbers have heart attacks, and patients with elevated LDL live to 90 with clean arteries. Cholesterol is part of the picture. It is not the picture. My goal today is to give you the full picture, clearly, honestly, and in language you can use to take action and have better, more productive conversations with your physician. If this series has been valuable to you, please subscribe and share this episode with someone you care about. Cardiovascular disease is the most preventable cause of death in America. The knowledge exists. It just needs to reach the right people. And now, let us talk about your heart. Let me reframe cardiovascular disease from the ground up, because the dominant model that most people carry is both incomplete and misleading in important ways. The story begins not with cholesterol, but with the endothelium, the single cell layer lining the inside of every blood vessel in your body. The endothelium is not passive plumbing. It is an active endocrine organ that produces nitric oxide to dilate vessels, regulates clotting, manages inflammatory signaling, and controls the movement of molecules between the bloodstream and vessel walls. When the endothelium is damaged by chronic inflammation, oxidative stress, high blood glucose, elevated insulin, high blood pressure, or cigarette smoke, it becomes dysfunctional. It produces less nitric oxide. It becomes more permeable. and it begins to attract LDL particles into the vessel wall, where they are oxidized by free radicals and trigger an immune response. Macrophages, immune cells, arrive to clean up the oxidized LDL. They engulf it and become what pathologists call foam cells, which accumulate beneath the endothelium to form the fatty streaks that are the earliest stage of atherosclerotic plaque. As inflammation continues, the plaque grows. It recruits smooth muscle cells, it calcifies, it narrows the vessel. And when a vulnerable plaque ruptures, triggered by an acute inflammatory event, it releases its contents into the bloodstream, forming a clot that can block coronary or cerebral arteries entirely. This is not primarily a story about too much cholesterol floating in the blood. It is a story about endothelial damage, oxidative stress, inflammation, and immune activation. Cholesterol is involved, but as a passenger in a process driven by inflammation, not as the primary instigator. A landmark study published in the New England Journal of Medicine, the Jupiter trial, randomized 17,000 people with normal LDL but elevated high-sensitivity C-reactive protein, the inflammatory marker, to receive either a statin or a placebo. The statin dramatically reduced cardiovascular events, not because it primarily lowered LDL, but because statins, independent of their cholesterol-lowering effect, have significant anti-inflammatory properties. The trial demonstrated that inflammation, not just LDL, is a primary driver of cardiovascular risk. Understanding this changes everything about how you approach prevention. Now let me give you the specific biomarkers that the current cardiovascular research identifies as the most meaningful predictors of risk, and which ones belong in a conversation that goes beyond the standard lipid panel. The first is high-sensitivity C-reactive protein, hs-CRP. We have discussed this across multiple episodes in this series because it appears everywhere, in inflammation, in gut health, in biological aging, and now in cardiovascular risk. An hs-CRP above 3 milligrams per liter doubles cardiovascular risk independent of LDL levels. It is inexpensive, widely available, and covered by most insurance plans. Yet it is not part of standard cardiovascular screening for most adults. Ask for it. The second is ApoB, apolipoprotein B. This is the protein that sits on the surface of LDL and other atherogenic lipoprotein particles. Every LDL particle has exactly one ApoB molecule. So ApoB tells you the actual number of LDL particles circulating in your bloodstream, which is more predictive of risk than the total mass of LDL cholesterol. Two people can have identical LDL cholesterol numbers but very different ApoB levels, meaning very different numbers of particles available to penetrate the arterial wall. A study published in the Journal of the American College of Cardiology found that ApoB was a significantly stronger predictor of cardiovascular events than LDL cholesterol. This test is available but not routinely ordered. It should be. The third is fasting insulin. Insulin resistance, which precedes type 2 diabetes by years or decades, is one of the most powerful drivers of cardiovascular disease. It promotes visceral fat accumulation, drives endothelial dysfunction, increases triglycerides, reduces HDL, creates the small dense LDL particles that are most atherogenic, and promotes chronic inflammation. A study published in Circulation found that insulin resistance was present in the majority of patients with premature cardiovascular disease. Fasting glucose alone misses early insulin resistance. Fasting insulin, or better, a HOMA-IR calculation combining fasting glucose and insulin, gives you the picture glucose alone cannot. The fourth is Lp(a), lipoprotein(a). This is a genetically determined lipoprotein particle that is largely independent of diet and lifestyle. Elevated Lp(a), present in approximately 20% of the population, is one of the strongest independent risk factors for premature cardiovascular disease and aortic stenosis. It is essentially invisible to standard lipid panels. Yet it is a one-time test that tells you something fundamental about your inherent vascular risk profile. The American Heart Association now recommends that everyone have their Lp(a) measured at least once in their lifetime. Many people reaching 50 have never had it checked. The fifth is triglycerides and the triglyceride to HDL ratio. Elevated triglycerides, above 150 milligrams per deciliter, combined with low HDL, is a pattern strongly associated with insulin resistance and cardiovascular risk. A triglyceride to HDL ratio above 2 is a widely used clinical marker of metabolic cardiovascular risk. This is information available in a standard lipid panel that most physicians do not calculate or discuss, yet it tells you more about your metabolic cardiovascular health than LDL alone. A few years ago, I worked with a patient I will call Gary. He was 58, a retired firefighter from Austin, Texas. He had been seeing his primary care physician annually for years. Every year, his cholesterol came back borderline, and every year the conversation ended with a recommendation to eat less fat and consider a statin. Gary resisted the statin because his cholesterol numbers did not seem dramatically abnormal to him, and he felt fine. When Gary came to see me after a close colleague his age had a heart attack, we ran a comprehensive cardiovascular panel. His LDL was 128, technically borderline but not alarming. But his ApoB was significantly elevated, indicating a high particle number. His hs-CRP was 4.2, indicating significant systemic inflammation. His fasting insulin was high despite a normal fasting glucose, classic early insulin resistance. And his Lp(a) was elevated at 68 nanomoles per liter, placing him in a genuinely high-risk category that had never been identified. Gary was not fine. He had multiple converging cardiovascular risk factors that his standard lipid panel had entirely missed. We restructured his approach around inflammation control, insulin resistance reversal through a lower carbohydrate Mediterranean dietary pattern, resistance training for muscle glucose disposal, and targeted supplementation. His hs-CRP dropped to 1.1 within 4 months. His fasting insulin normalized. His ApoB decreased. The Lp(a), being genetic, remained elevated, which informed the decision to initiate a statin specifically targeted at his particle risk profile. Gary's story is not unusual. It is representative of how much cardiovascular risk is being missed by the standard conversation. And here is where the science becomes genuinely actionable. Because once you understand that cardiovascular disease is an inflammatory, metabolic disease, rather than simply a cholesterol problem, the interventions become both clearer and more powerful than anything a single number on a lipid panel could guide. Let me give you the dietary evidence, because this is where you have the most direct leverage. The Mediterranean dietary pattern has more robust cardiovascular outcome data than any other dietary approach in the scientific literature. The PREDIMED trial, a landmark randomized controlled trial published in the New England Journal of Medicine, assigned over 7,000 high-risk adults to either a Mediterranean diet supplemented with extra virgin olive oil, a Mediterranean diet supplemented with nuts, or a low-fat control diet. The trial was stopped early because the cardiovascular event reduction in the Mediterranean groups was so significant that it was considered unethical to continue withholding the intervention from the control group. The Mediterranean diet reduced major cardiovascular events by approximately 30%. The key components of that benefit were extra virgin olive oil, at least 4 tablespoons per day in the trial, and a diet rich in fish, vegetables, legumes, nuts, and whole fruits, with minimal processed food and refined carbohydrates. Omega-3 fatty acids from fatty fish deserve specific mention. A meta-analysis published in the Journal of the American Heart Association found that EPA and DHA supplementation significantly reduced cardiovascular mortality and non-fatal myocardial infarction. A high-dose omega-3 trial called Reduce It, published in the New England Journal of Medicine, found that 4 grams per day of a prescription omega-3 preparation reduced major cardiovascular events by 25% in patients with elevated triglycerides on statin therapy. The evidence for omega-3s in cardiovascular protection is among the strongest in nutritional medicine. Reducing refined carbohydrates and added sugars is critical for the insulin resistance component of cardiovascular risk. A study published in JAMA Internal Medicine followed over 40,000 adults and found that those consuming 17 to 21% of their calories from added sugar had a 38% higher risk of cardiovascular mortality compared to those consuming less than 8%. Sugar drives triglycerides, reduces HDL, promotes small dense LDL, and fuels the endothelial inflammation that initiates atherosclerosis. This is a more mechanistically direct cardiovascular risk factor than saturated fat for most people, yet it receives far less clinical attention. The lifestyle factors with the most compelling cardiovascular outcome evidence extend well beyond diet, and I want to give each of them the weight the research supports. Exercise is arguably the most powerful cardiovascular intervention available, with outcome data that rivals or exceeds the most effective medications. A meta-analysis published in the British Medical Journal comparing exercise to drug therapy across multiple conditions found that exercise was equally effective to statin therapy for secondary cardiovascular prevention and significantly more effective than medication for stroke rehabilitation. Exercise improves endothelial function, reduces inflammation, improves insulin sensitivity, increases HDL, reduces triglycerides, lowers resting blood pressure, and promotes the development of coronary collateral circulation, alternative blood supply routes that protect cardiac tissue if a primary vessel becomes compromised. The type of exercise that has the most robust cardiovascular data includes both moderate continuous aerobic activity, brisk walking, cycling, swimming, and high-intensity interval training. A study published in the European Heart Journal found that even 10 minutes of vigorous activity per day was associated with significant reduction in cardiovascular mortality. The message for people who feel they cannot commit to long exercise sessions is encouraging. Intensity compensates substantially for duration. Sleep, our 6th episode, connects to cardiovascular health through multiple mechanisms. Elevated blood pressure is one of the most direct. Blood pressure normally drops during sleep, a phenomenon called nocturnal dipping, and this drop is essential for arterial repair. Adults who do not experience adequate nocturnal dipping have significantly higher rates of cardiovascular events. A study published in the European Heart Journal found that sleeping fewer than 6 hours per night was associated with a 48% increased risk of coronary heart disease. Every sleep intervention from our previous episode is simultaneously a cardiovascular intervention. Psychological stress activates the sympathetic nervous system, elevates cortisol, increases heart rate and blood pressure, promotes platelet aggregation, the clumping of blood cells that initiates clotting, and drives inflammatory cytokine release. The landmark Interheart study, published in the Lancet and covering over 52 countries, identified psychosocial stress as one of the 9 modifiable risk factors accounting for over 90% of heart attack risk globally. Managing chronic stress is not peripheral to cardiovascular health. It is central to it. I want to address statins directly because they are the most prescribed cardiovascular medication in the world, and because the conversation around them is frequently polarized in ways that serve patients poorly. Statins are among the most effective interventions we have for secondary prevention, meaning for people who have already had a cardiovascular event or who have established atherosclerotic disease. The evidence for secondary prevention is robust, consistent across multiple large trials, and clinically meaningful. For this group, statins save lives. That is not in dispute. For primary prevention, reducing risk in people who have not yet had an event, the picture is more nuanced. The benefit is real but more modest. A meta-analysis published in the Lancet found that statins reduced major cardiovascular events by approximately 25% per millimole reduction in LDL. But because the absolute risk of a first event is lower in primary prevention populations, the absolute risk reduction is also lower. Whether that benefit outweighs the risks, which include myopathy, potential effects on insulin sensitivity, and a small increase in type 2 diabetes risk, depends substantially on individual risk profile. What I want you to take from this is not that statins are good or bad universally. It is that the decision to take a statin should be made on the basis of comprehensive risk assessment, including hs-CRP, ApoB, Lp(a), and insulin resistance status, not on LDL alone, and that statins work most powerfully when combined with, not as a substitute for, the dietary and lifestyle interventions we have discussed today. Here is your cardiovascular action plan. 1. Request a comprehensive cardiovascular panel at your next appointment. Beyond the standard lipid panel, ask specifically for hs-CRP, ApoB, fasting insulin, and Lp(a). If your physician is unfamiliar with ApoB or Lp(a), reference the American Heart Association's 2023 guidance on advanced lipid testing, which endorses both. 2. Calculate your triglyceride to HDL ratio from your existing lipid panel. Divide your triglyceride number by your HDL. A ratio above 2 indicates metabolic cardiovascular risk that warrants dietary attention regardless of your LDL. 3. Adopt a Mediterranean dietary pattern as your foundation. Extra virgin olive oil as your primary fat. Fatty fish at least twice per week. Abundant vegetables, legumes, and whole fruits. Minimal refined carbohydrates and added sugars. The PREDIMED evidence is as strong as any dietary intervention in medicine. 4. Reduce your added sugar intake as a specific, targeted cardiovascular intervention. Read labels. Added sugar appears under more than 60 different names. The American Heart Association recommends no more than 25 grams per day for women and 36 grams for men. Most Americans consume 2 to 3 times that amount. 5. Commit to consistent aerobic exercise and resistance training. 30 minutes of moderate aerobic activity most days of the week, combined with resistance training twice weekly, addresses endothelial function, insulin resistance, inflammation, and lipid profiles simultaneously. 6. Treat your sleep, your stress, and your inflammatory load as cardiovascular risk factors, because the research is unambiguous that they are. Every episode in this series has been, in part, a cardiovascular episode. Let me bring everything together. Cardiovascular disease kills more Americans than any other condition, and the dominant framework for preventing it, lower your cholesterol, take a statin, eat less fat, is a significant underestimate of both the complexity of the disease and the power of the interventions available to you. Heart disease is an inflammatory disease. It is driven by endothelial dysfunction, insulin resistance, oxidative stress, and the accumulation of atherogenic particles that standard testing does not fully capture. The biomarkers that predict it most accurately, hs-CRP, ApoB, fasting insulin, Lp(a), are available, affordable, and largely ignored by standard practice. The interventions that work most powerfully: a Mediterranean dietary pattern, omega-3 fatty acids, resistance training, sleep restoration, stress management, and inflammation control, are the same interventions that protect your brain, your mitochondria, your gut, your muscles, and your biological age. They are not disease-specific tools. They are the foundations of the biology of health itself. Gary understood that once he saw the full picture, and the full picture changed everything about how he approached his health. If today's episode gave you something genuinely useful, please like this video, subscribe to the channel, and share it with someone who cares about their heart. Leave me a comment. Tell me which biomarker from today's episode you are going to ask for first. I read every one. In our next episode, we are going to talk about something that is quietly affecting cognitive function in millions of Americans over 50 and is almost never discussed in mainstream medicine: the specific nutrients the aging brain needs that it is increasingly not getting, why the brain becomes selectively vulnerable to deficiency after 50, and what the research says about protecting and even restoring cognitive function through targeted nutritional support. I think it will be one of the most practical and surprising episodes yet. Until then, take care of yourself from the inside out.